multicultural realities we described in the previous presentation and their growing complexity among us present some significant and serious challenges for healthcare. Let's think first about the way this reality challenges the professional-patient relationship. We've already seen how important and how difficult high-quality communication between patient and professional is in the medical context. In the face of a medical crisis, patients often have great difficulty describing their symptoms, and more importantly, their values to healthcare professionals as they try to discover together the appropriate course of action. Imagine that difficulty when patient and professional speak different languages. It may well be that their communication will have to take place through a translator. Or maybe both speak English, but one or the other is speaking English as a second or even a third language, and their level of proficiency isn't sufficient for communicating the complex and often subjective matters that are being dealt with in the face of a medical crisis and decisions about appropriate medical care. Of course, there's diversity among healthcare professionals and not just among patients, so don't think about this just in terms of an English-speaking physician or healthcare professional working with a Hispanic patient, for example. Imagine a Chinese-American physician who's working with an Hispanic patient. Both are communicating in English, but English may be a second language, or may well be a second language for both. The challenges to communication in professional-patient relationships go beyond issues related to language, however. Language is only one aspect of culture, even if one of the most evident. But the challenges to communication have to do as well with different worldviews, different values, different styles of communication. People from different cultural backgrounds bring different understandings of health and sickness or disease, different ways in which scientific knowledge is integrated with and assimilated with other kinds of knowledge, different ways in which religious beliefs and scientific data are merged, different beliefs about the meaning of life and death. All of this adds significantly to the challenge of communication and significantly to the challenges of professional-patient relationships in a cross-cultural context. Cultural diversity often interacts with political, social, and economic inequalities. We will talk later about health inequities or health disparities among various racial and ethnic groups. At this point, where our concern is on the professional-patient relationship, it's enough simply to note that many immigrants and people of color, people from cultures different from our own, are also wrestling with poverty, a lack of social status, or diminished political power. All these have an impact as well on a patient's relationship to healthcare professionals. Of course, these realities also impact significant numbers of poor working-class white people and affects their relationships to healthcare professionals. Trust is essential to the professional-patient relationship. But where communication is difficult, maybe because of different languages, where there are different worldviews and values, trust is undermined. When, as well, patients are poor, lack social status, political power, uncertainty, suspicion, and distrust is only amplified, creating significant challenges to the establishment of an effective and therapeutic professional-patient relationship. One of the ways in which a variety of institutions have tried to rise to the challenges of working in a multicultural society is through the implementation of what are called cultural competence programs. Medical schools, nursing schools, and hospitals have tried to assure that healthcare professionals have what is called cultural competence. Oftentimes, such programs have tried only to make sure that healthcare professionals had at least some superficial knowledge of the beliefs, practices, and folkways of the people from different cultures which they encounter. Such approaches have come under a lot of criticism, however. Teaching people about the distinctive beliefs and practices of various cultures often was thought to have led to harmful stereotyping rather than genuine understanding. And the very idea of cultural competence, it has been said, creates the false impression that one could achieve an adequate level of knowledge about different cultures such that you can understand the people in front of you without an ongoing process of openness and listening. You may well recall from earlier in the semester the video by Sayantani Dasgupta where she critiques the idea of narrative competence, which is very much parallel to and similar to the idea of cultural competence. She notes that some have insisted that rather than thinking we didn't need to know certain basic facts about others' cultures if we are to interact with them appropriately, what we really need to do is to become self-aware of our culturally shaped perspectives and values and our own prejudices or biases. And to recognize that no matter how hard we try, we will never fully understand another individual, particularly one shaped by another culture. With this self-awareness and with humility about what we can truly understand about another, we will remain curious, open, and attentive. So she advocates for cultural and narrative humility rather than competence. I do think it's probably the case that a problem here is that the actual practice of cultural competency programs has not lived up to what the advocates and theorists of cultural competency have actually understood that idea to mean. For example, the National Center for Cultural Competence at Georgetown University makes clear that cultural competence involves much, much more than some superficial cultural knowledge that one can rather easily obtain about people from other cultures. Among other things, they insist that cultural competence requires that organizations have a capacity to value diversity, conduct self-assessment, manage the dynamics of difference, acquire and institutionalize cultural knowledge, and adapt to diversity and the cultural contexts of the communities they serve. They cite a U.S. Department of Health and Human Services definition that applies a similar understanding of cultural competence to the individual. At the individual level, this means an examination of one's own attitude and values, the acquisition of the values, knowledge, skills, and attributes that will allow an individual to work appropriately in cross-cultural situations. Individuals with cultural competence, they say, value diversity and similarities among all peoples, understand and effectively respond to cultural differences, and engage in cultural self-assessment. I think it's fair to say then that teaching cultural competence, as envisioned by its advocates and early theoreticians, is a significant attempt to respond to the challenges of work in a multicultural society. And it includes what Dasgupta meant by cultural humility. Surely, working effectively with people from a culture different from one's own requires some basic knowledge about that culture. But more than simple mastery of a few basic facts, it requires an awareness of one's own cultural formation and an attitude of respect and appreciation rather than fear or mistrust in the face of difference. It values diversity. And above all, maybe, it requires an awareness that one can never fully comprehend another person, especially a person of another culture, who always remains somewhat of a mystery to us, as we often are to ourselves.